The person has a self-conceived notion, thanks to Dr. Google, where that MRI is the most important investigation. MRI is not the most important investigation. For me as a spine specialist, what I rely more is on a simple X-ray. The most important thing. If you go to a non-specialized center treating an X-ray of back pain, 99% times the X-ray is taken lying down. If you see, most of the pain comes when you're standing and sitting. So it is not in the right clinical perspective to have an X-ray even done lying down. The basic dictum of taking X-ray is standing X-ray.
You should not unnecessarily over-investigate.
First of all, don't do any investigation without seeing a specialist.
Voices shaping the future of medicine. Stories, knowledge, experience. More for life.
Welcome to the new episode on Project Heal. As you know, Project Heal showcases multiple solutions in the healthcare space. And today we are very happy to have Dr. Ranjith Unnikrishnan from KIMS Trivandrum to talk about one of the biggest problems in orthopedics, and that is spine problems. 1 out of 7 people suffer from spine problem. More than 600 million people suffer from back pain. Spine problems is a very common problem, which you would have seen even in many of your family members. So today we have an expert from the field, Dr. Ranjith Unnikrishnan, who is going to talk about what are these problems, how this can be mitigated, what are the new technologies which can help solve these problems, what are the do's and don'ts, and what are the new techniques which are going to revolutionize spine treatment. Over to Dr. Ranjith.
Hi, sir. Thank you. Very glad to be here in this episode of Project Heal. I really appreciate the team behind Project Heal in taking the efforts and trying to spread awareness among doctors as well as general laymen regarding the various spine problems and the possible solutions. Spine problems or spine issues or disorders, the crux of it is that most of it can be avoided or prevented by adequate preventive measures, provided you know what is it. Like the way you treat hypertension and diabetes to prevent a complication of a heart attack or a stroke. Similarly, if you take a few corrective measures in the way you sit, stand, walk, work, it goes a long way in preventing a lot of spinal disorders, which the biggest gamut of it is because of degenerative back pain or work-related or sports-related pain. So most of it stems from the fact that you should know how it can be avoided. For that, you should know why it happens. So in a regular spine clinic, when you see a patient, nearly 70 to 80% of the people come along with back or leg pain, leg pain. A few of them also come with issues due to neurologic compression or infection or deformity, trauma, etc. When somebody visits a spine clinic or seeks help for a spine disorder, a vast majority seek help for pain. It could be back pain or neck pain or leg pain or associated issues like numbness. Few also seek help for infections or deformities, tumors, etc. So when we look at pain, like we say, pain is not a diagnosis, it's a symptom. So the role of the doctor or the clinician lies in trying to know why and where and how is the pain coming from. So when you really, because I was asked to know what are the common spine disorders. So if you can say 70 to 80% of the spectrum of people who seek help come to us for pain. Now, here is the catch regarding it. Does every back and neck pain need a spine specialist evaluation? The answer is no. Next question is, should every difficulty in walking or difficulty in lifting something or supposed weakness needs evaluation by a specialist? The answer is yes. So if I have to put it, every pain does not need a spine specialist consultation, but every weakness does need a spine specialist consultation. To add to it, if you have issues like you have a fall, or you have a fever, or you have a pain at rest, etc., these are what we call as the red flags, which also need to be evaluated, because most of the time these are symptoms which lead to a diagnosis, which if made or done earlier appropriately can avoid long-standing, probably devastating sequelae or consequences. So for that, the most important thing is to know when to seek specialist attention. I would not say that when to seek help, when to seek specialist attention. Like few symptoms, like say you have back or neck pain which has been there for weeks or months together, or you have pain at rest, you are not able to sleep well because of the pain, or you associate a leg pain or arm pain or numbness or weakness, or you also notice that you're losing weight or losing appetite, and you notice swelling elsewhere, etc. These are features which definitely needs a specialist evaluation. Now, there is again another crux in it. Does every doctor who comes to a specialist or a spine specialist, I would not say a surgeon as such, who comes to a specialist, need to have an investigation like an X-ray or an MRI? The answer is no. There are definite guidelines as to when you need to have an X-ray, when you need to have an MRI. If I may add, a vast majority of the misconceptions regarding spine disorders and deciding treatment is because of unindicated or ill-advised MRI scans or CT scans or X-rays. Now the question naturally was why? Because any evaluation of a person who comes with pain, the primary core thing is clinical evaluation. All the investigations will aid or help in making a diagnosis, not the diagnosis. Now, the difference, let me try and explain. Now, if you see any MRI report, which is naturally in English, and nearly 90% of the population can read English, or if they know how to use ChatGPT to translate English into their vernacular language. So, if you see a report, it'll be a one-page report saying da 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 this that and then that is it. So when you go through it, somebody who has a 3 weeks or 4 weeks of back pain gets an MRI done by himself or by anybody's advice, sees a report and then comes to believe that there is a problem with him. Right? It's but natural, because you have a problem, you see an MRI and then you see a report, it's a 2-page report with saying XYZ. You should always understand that the radiologist who reports the MRI or who gives a report is giving what he sees in the MRI films, which does not mean it's a disease, right? It is the interpretation of that findings based on the clinical examination and evaluation by the specialist, which comes to a diagnosis. So I would strictly advise doctors as well as people who have back pain not to get unnecessary investigations, because that is the biggest reason why people seek specialist advice for fear of having a disease. Naturally, you should not overlook these salient features or points which needs further evaluation. What are they? If I can again enlist them, it is pain for months together, rest pain along with numbness in legs, weakness in legs, difficulty in passing urine on motion, difficulty in walking, climbing steps, weight loss, fever, fall, pain in extremes of age, very young and very elderly. All these need to be evaluated, and then because most of them, the pain is because of degenerative or posture issues. So when we look at the spectrum of people who come to us with these disorders, it's a common question we ask, our training students. I think, what is the most common cause of back pain? So the next question has to be, is it acute back pain or chronic back pain? So then the question is, what is acute, what is chronic? Acute, which happens within 24 hours. Chronic, which can be anything more than few weeks or days or months together. So the most common cause of chronic back pain is not degeneration. It is not trauma. It is not fault. It is postural backache. So a vast majority of people, so most of us who today sit and work or work in an IT profession or work in an office job, have got sedentary job for a long time, you get pain not because you have got degeneration. You get pain because you got postural backache.
So can we bifurcate that into a lifestyle disease, a type of lifestyle
Well,
disorder?
it is not essentially a lifestyle disorder. It is because of a disorder or an issue because of not knowing what is happening. So, if you think like that, a person who works at home, a homemaker, why should she have backache? She gets backache. It is not because she has got a lifestyle disorder. It is because she does not know, or she, when she has pain, there is some reason why she is not doing her daily job in the right ergonomic way. That is the reason for the pain. So then the next question, doctor, is because I stretch and sit in my back or I look in the mobile and neck? The answer is no. Postural backache is not because of bad posture. It's because of bad postural muscles. So you have to definitely understand the difference between bad posture and bad postural muscles. So the most common cause of chronic back pain is postural backache, which does not need investigations. That is the thing to understand. So if you evaluate and try to image and x-ray every possible postural backache, you will have a whole lot of findings on the MRI, which the person reads and believes that he has got a disease.
This is a very important point you're making, because when the patient goes to a family physician or an orthopod, this is a very common thing. When you have a back pain, go for at least for an X-ray. And the common saying is, the doctor treats the patient, not the X-ray. And you're coming very close to that point that,
And that's a very true, sir. And even when you have an X-ray or an MRI, the interesting fact is that the way it is interpreted is totally different from the way it is read in the report. Like when a spine specialist or a surgeon sees an MRI, he seldom looks at the report. If he's a trained or a fellowship trained or a specialist surgeon, no? We look at the MRI as an extension of our examination. The report is probably to confirm something in doubt or something to confirm, not to read the whole report. Because when I look at the patient or examine him, I know most like the why the pain is coming from and try and see if that is there in the MRI. Whereas if a non-spine specialist sees the MRI, it is as good as reading the English report by a layman. Now, he or she will look at what the radiologist felt and think that there might be a disorder. So that adds to the, I'm not in any way demeaning any specialist. It is like we joke, it's like an orthopedic surgeon reading an ECG. I am not trained to read an ECG. I am not trained to read an echocardiogram. It is not my forte, not my cup of tea. It has got a specialist cardiologist who can read it. Similarly, is an MRI being read by a gynecologist, or I don't mean to demean gynecology as such. It is the way, because the training is such. So it's very important for us to interpret the MRI or the imaging in the right perspective. And I am emphasizing this point because most of these consultations can be avoided if you don't do unnecessary imaging.
So if a patient is recommended by a non-spine surgeon or a general doctor for an X-ray or MRI, what do you advise them to do?
So that's again a good question, sir. So when a patient comes to me with months together of backache, if in my history or my evaluation I come to feel it's because of degenerative backache, which is a cause of chronic back pain, the most information what I get is not from the MRI, it is from a simple X-ray. Whereas a person has a self-conceived notion, thanks to Dr. Google, where that MRI is the most important investigation. MRI is not the most important investigation. For me as a spine specialist, what I rely more is on a simple X-ray. Now, X-ray tells me a lot of information which I need, which is important for a chronic backache patient. The most important thing. If you go to a non-specialized center treating an X-ray of a back pain, 99% times the X-ray is taken lying down. If you see, most of the pain comes when you're standing and sitting. So it is not in the right clinical perspective to have an X-ray even done lying down. So in my specialist or any center where which is used to treating spine disorders, the basic dictum of taking X-ray is standing X-ray. So right from there, the interpretation goes wrong. So you have to have the right set of tools to have come to the right set of a diagnosis. So that is where it starts. So for me, somebody who comes with backache, if I evaluate and feel it needs an X-ray, it should be a standing lateral X-ray. Whereas if you go to a non-specialized center who's not understanding this factor, you'll have a center with an X-ray lying down, which actually does not give much information. So I would say that if you're having a chronic backache, and first of all, don't do any investigation without seeing a specialist. For whatever reasons, whenever you do any investigation, it's not like going to a lab and getting a blood report done to look at your blood sugar or your creatinine. No. Any imaging investigation has to be seen with the right perspective. So please don't get it done. It will only add to your confusion and your woes. Especially high-end imaging like CT scans, MRIs, PET scans, etc. And it's not uncommon for me to see people in their 30s or 40s come with like a backache of 5 months and 5 MRIs. It is not uncommon, and I don't blame them alone. It is understanding of the problem. So it's very, very fundamental for us to know when to investigate and when to image and when to come to a conclusion. Whereas equally important is the clinical situation where patient has these red flags, what I mentioned some time back, and going to a scientific specialist and having a disorder which is thought to be degenerative and then ending up with further complications.
So it's a very important message which goes through this podcast to the the general masses or the people the layman of medical science, is that you should not unnecessarily over investigate even through the basic X-ray and MRI. Go to a proper spine specialist.
Also,
and
don't under investigate.
Don't under investigate.
That's also equally important.
Okay.
Because like I mentioned these red flags to you. So these red flags, we always say that the eye does not see what the mind does not know. So if the mind of the clinician or the patient who sees, or the person who sees his patient has got in the background these factors, when the patient tells this to you, when you take a history, he tells these features, you should be knowing the red flag and imaging when required. Because if not, I see people come to us with late stage cancers, etc. So which could have been primarily treated effectively, probably diagnosed early. So when you go back and look at the history recall, it's very often that they went to XYZ person, he thought, no, this is degeneration, he took an MRI probably was tele-reported or probably not actually evaluated, and told as degenerative back pain, whereas it was infection or tumor, and ends up with a complication, right? These are the fallacies of the system, which in our country, it's easy for us to go to any system, any doctor, anybody in there, and take a call on it and then trust or not trust. So there are these I'll not say they are a majority, they are a minority, but for a patient, it is majority, it's 100%. So we should know these red flags, etc., when to go and evaluate, and when to have the appropriate investigation, and when to seek medical help.
So in so many years of your practice, do you see a change in the pattern of spinal problems coming to you? What about 20 years back and now, the current generation having a different type of spine problems? I know we touched upon lifestyle and postural things, but do you see a change?
Sir, it's a very good question. There are two perspectives on it. One is new kind of disorders. I would say no. Number two, earlier diagnosis. I would say yes. Number three, more misconceptions. Yes. Misconceptions part has increased immensely in the last, say, 10-15 years because of the easy or unstandardized information available in the internet and anywhere. If you come to the new onset disorders, no. The part of kind of disorders which have become more common because 15 years or 20 years back we not have so much of IT professionals. neither we call that text neck syndrome, people looking phones and typing. So that since there were no mobile phones, looking forward and typing too much, we call that text neck, keep bending and texting too much, you get postural neck pain, right? So the text neck syndrome was not so common. So much so was the postural backache because of long sitting hours and lack of exercises, lack of mobility was not so common. Earlier diagnosis has been now much because of one of the offshoots of earlier imaging is picking up small tumors, etc., very early, because the imaging was done for another reason, picked up earlier. So there is far more earlier diagnosis, and in few subset of disorders like cancers or spinal infections, today most of the time if we can diagnose early when it is in a contained space, we can avoid massive surgeries, or we can get tissue diagnosed, etc., by many interventional procedures like CT guided or ultrasound guided, image guided aspirations. So we are getting to know early disorders and getting to have more effective medical management and more effective non-surgical management of this disorders. That's one real good change which has happened as per to diagnostic measures. Regarding the misconception errors, because of like what I said, the easy availability of imaging modalities for anybody and any specialty, and the easy unstandardized or non-medical information in the internet, the doubts and misdiagnosis has been rampant. It's like if I make a post about something on the internet, let be on some blog, or I add to something, I am adding to the Google database of the information, right? Now what I say and what you say and what he says, everything is logged in the internet. When you do a Google search, when you do a AI search or ChatGPT search, it does not know how to classify the information and from whom it is coming from. But what I say comes as data. You, based on the popularity of my search, you might be getting information which is not probably truth.
So that will pop up first and you get that first info.
You tend to believe that is true, and you tend to believe you have a disease, right? So always it's like, do you go to court if you have a case by looking at Google? No, you have to take services from a qualified lawyer, right? Because he is certified and trained to do the job. But medicine, anybody can go to a pharmacist in India, pop up a pill and buy it, right? So it doesn't happen with law, it doesn't happen with legislation, but it happens with medicine. So this fallacy is adding a lot to the misdiagnosis or mistreatment or illogical treatment of disorders, right? So that's one thing which has happened with regard to the third part of your question.
So in the deformity, area, you see some drop of, the scoliosis cases, which used to happen when because I'm in the industry, in spine industry for more than 20 years. So I've seen good number of scoliosis in the early part. Do you see a drop in the numbers and some?
Well, I would not say the incidence of scoliosis has decreased. No, it has not decreased, but the early diagnosis has increased. If you look at spine deformity as such, especially pediatric spine deformity like scoliosis, kyphosis, the crux of the treatment is in early diagnosis. We have enough data to today show that if you diagnose a deformity very early in life, 70% times we can avoid surgery. We can avoid surgery by appropriate bracing measures, not by exercises or physical therapy. It is by appropriate bracing measures. So, because of the awareness of the general public and parents and teachers and even doctors as such, early diagnosis of scoliosis or deformities is happening, and that is leading to early bracing, etc., and thus less number of surgical indications. That's a very good welcome change. With respect to degenerative deformities like adults or middle-aged women or men, the safety profile of surgery has increased so much, and the predictability of surgery is increased so much that we as surgeons feel safe in recommending and doing surgery in 70s or 80s of years of age. Because, as I say, getting old is not the patient's mistake. It is not a crime. It is but natural and biologic. Whether to live with the pain or be independent till death is the patient's or the person's choice. If I am 90, I want to live pain free, and I am offered a treatment by a doctor who is capable of managing me, I'll go ahead with it because my need is independent, pain free life till my death. Getting old is not my mistake. I don't want to be told that, well, it is age, you have to live with it. I will not accept it because I want to be mobile as much as I want. So that change has happened a lot in the
Deformity segment also.
deformity degenerative segment. And as surgeons, as our teams, our anesthesia team, ICU team, rehab teams have improved so much that we are more or less confident of giving predictable outcomes. Mind you, it does not mean there are no complications, but we are able to stratify the people better. We are able to pre-operatively do a risk stratification and explain to the patient with better data and experience that what are your goals of treatment if you go for XYZ, which probably was not true 20 years ago when what you mentioned some time back, because today we have more robust and granular data and more surgical experience thanks to the advancement in anesthesia, instrumentation, monitoring, etc.
So one more question on the pathology before we move into the technology part is that cancer is on the increase in India. So do you get large number of spine tumors because of metastasis or?
Yes, sir. That's again a good question, because if you look at spine tumor as such, the most common spine tumor is metastasis, meaning disease happening somewhere spread to the spine. So metastatic spine disorders we are able to diagnose much more earlier thanks to early imaging, and even when diagnosed early because of many interventional procedures like CT guided ablations, biopsy, etc., we are able to avoid more radical and massive surgeries which we are doing it earlier. So early diagnosis, early treatment, better outcomes. So that is a big change, and with the advent of nuclear diagnostics and PET scans, etc., it's been tremendous amount of advances has come with respect to diagnosis. So if I can put you in simple terms, today I seldom do a biopsy in a spine to know a tumor before I have the requisite amount of investigation, including a PET scan. So my indication of biopsy has decreased so much in last 10 years because I'm able to make a diagnosis without putting a knife or needle inside. So that has happened because of the advances in technology.
So what kind of technological advancements have really improved both the diagnosis and the outcomes in spine procedures?
So 25 years back, you would take a phone and call me the landline, right? You have to walk to the phone and call me. Today in your phone, you'll pick up your phone and call me in your phone, right? Today you can even voice dial me. Similarly, that changes thankfully happened to medicine and spine as such, sir. And a huge advance has made in last 10 years with respect to emerging technology in spine surgery. First and foremost, apart from good implant and anesthesia technology, the first breakthrough was intraoperative neuromonitoring. Because whenever we do these surgeries today, which involve surgery in the spinal column as well as spinal cord, one most devastating complication which we dread is paralysis.
Neural damage.
If I may say, the technical error in implant placement with which can happen in the hands of an inexperienced surgeon is almost minimized or made zero if he has access to these navigation technologies. Let me re-emphasize, having a navigation technology does not change the surgical indication. The surgical indication is the same. It is not technology driven, it is patient need driven. It is never technology or gizmo driven, right? So this unfortunate trend of having to undergo robotic surgery because of having a robot is not correct, right? Robotic surgery, I'm just doing robo because that is a current thing. Every patient asks me, doctor, do you have a robo with
It's
you?
a good example, yeah.
So I would say that there are places where robotic surgery has made huge differences, and there are places where a robotic surgery is still just a gadget, and there are places where robotic surgery is useless. So, spine is an avenue where robotic surgery is okay, not has made a huge change like say prostate surgery or endourology. It is not that. It is still a gadget to be used by a person who knows how to use a gadget. If you know how to play PSP, does not mean that you will be able to sit on the console and do the surgery, right? So you have to have that amount of discretion. So this is a huge difference, but where it is there, it has made huge changes. But most important is in early diagnostics. Early diagnostic and things like proton beam therapy, etc., which is actually a thing which has happened in cancer care, has radically changed the outcomes in many spinal disorders. Like there is a particular tumor called chordoma of the spine. It was a surgery which happens it's a tumor which happens in very odd locations. It happened in the sacrum, in the pelvis, or in the C2 vertebrae. These were surgical corridors which we had to access with lot of morbidity.
So it was like blind spots for you? No.
It is not blind spot. It was a spot well known, but to reach there, we had to do a lot of collateral damage to reach there.
Okay.
So the surgical access related problem was more dreadful than the disease primarily. So today, because of proton beam therapy, etc., you don't have to even put a needle inside. It
So you
can be
can
so
target
easily
it and
targeted therapy. So it got beautiful, wonderful outcomes. Next, the biggest advantage which is applicable to a common man is endoscopic or minimally invasive spine surgery, right? Like we always say, today very few surgeons or doctors or patients would want to have a 10-inch scar to remove an appendix if it is inflamed, because laparoscopic or appendicectomy is the rule, not an exception, right? Why? Because that are the better outcomes of the procedure. The morbidity of a 10-inch scar and cutting open the abdomen is still decreased. That does not mean that that is a solution for a burst abdomen, right? So you should know when to use what. When you extrapolate the same information to spine surgery, a vast majority of these so-called painful disorders, what we see in a practice, is because of degenerative disorders, which are because of disc prolapses or stenosis, etc., wherein the solution to the problem, if it does not respond to adequate time of non-surgical measures like physical therapy, exercise, etc., is to remove the piece which is pressing on the root, the so-called discectomy or disc removal. If I have to remove a 1 centimeter disc which is located in the spine, when I started my career 25 years ago, I had to open up 10 centimeters. From 10 centimeters, open so-called laminectomy. As years trained, we came down to a 2-inch microdiscectomy. From a 2-inch microdiscectomy, I came down to a 16 millimeter tubular discectomy. From there today, I am at a 8 millimeter endoscopic discectomy. Now, what has changed from 10 centimeter to 8 millimeter? It is not the disease, it is not the diagnosis, it is the collateral damage I do to remove that 8 millimeter fragment which has changed. Naturally, when my surgery, which is again an injury to the normal tissues, is minimized to remove that fragment, naturally my recovery is better or faster. So today I have patients who walk into the clinic today with so and so, has to go, they get the surgery done and walk back home same evening, not next day back, morning back. Why? Did the indication change? No. The disease changed? No. The way I removed it changed. Because my cut is minimal, my pull is minimal, naturally outcome is minimal, is better. So that is the change it has happened. So the so-called bed rest after a surgery is
that's almost gone.
almost gone or minimized. I have people today who have surgery right from the upper back to the lower back in their 70s who wake up and walk the next day morning. Why? It is not because the surgery has changed, that technique has changed. The post of pain relief has changed. The post of rehabilitation has changed. Anesthesia has changed. And when, as a specialist, we speak of data, we speak of outcomes. There is nothing in the world which is 100%, including spine surgery. When we speak of outcomes, we have two kind of outcomes. One is statistics, second is personal outcome. As the maturity of the surgeon increases or the database increases, we become more and more clear in our understanding of the problem and more clear in our advice of solutions and more clear in expecting complications. So that delivers, translates into better outcome for patients.
So, how many of these spine complex procedures you are able to do minimally invasive surgeries?
A vast majority of degenerative spine disorders like a cervical disc prolapse, lumbar disc prolapse, stenosis, listhesis, all can be today done minimally invasive. But surgeries like pediatric scoliosis is still done open because the technology or the demand or the need is not as such. But many of the degenerative lumbar scoliosis we can treat minimally invasive. I would like to add a note on this. Just because a technology is available and the surgeon knows how to do it, does not mean the patient is right for it. A lot of these procedures have got predictable outcomes when done at the right time for the right indication for the right team, not surgeon, team. Because if I have to do an endoscopic surgery, I am just a surgeon. I need good anesthesia. I need good OT setup. I need good equipment, good biomedical setup. Then comes to my outcome. So every procedure it is available does not mean it should be done. Many a time till I have patients where I told I'm going to remove disc in 8 mm hole. I have patients whom I open up 10 inches also, but for a different indication. Because for a particular patient at that age, is it worthwhile going through that long anesthesia to get to these outcome? It's a question, and that is where the experience or the care of the team lies. I again use the word predictable outcomes. So that's what which we all want today. When you buy a car that it can have an accident one day. You don't want it to happen. Will you go and buy a car knowing that the brake has failed? Similarly is with you will want money to buy an XYZ brand, paying a premium because it's more safe. Similarly is coming to surgery. You many a times I get this question often asked by my people who come to me, doctor, this surgery is so expensive. Why is it? Why not do this way? So I always ask the question, so you have a car? Really? Yes. You want insurance? Yes. Why do you take the insurance? Because if you have an accident, you have to pay for it. Similarly, is the cost of surgery. We have all the technologies ready because in case you have a failure, we cannot put our hands up. We should pull you out. So that's what you have this expense is part of the safety net. Because God forbid you are that 1% guy who has it. If you don't have the insurance backup, you will not be able to. By insurance I mean here equipment backup, medical backup. You will not be able to be salvaged. So that's what we pay for.
So, I asked a similar question to one of your colleague, and he answered, Mohan, a carpenter with a hammer sees a nail everywhere. So, man with an endoscope cannot see every patient as a patient for endoscopy.
That's true with anything in surgery. Yeah. It's very much, that's why I said a vast gamut of my practice. I would say 80% of my practice is still MIS, 20% is still open. Because there are patients whom I know out of my experience and knowledge that he is not the right person. I can do it endoscopically, but he is not suited for it medically. He is not suited medically. So what the patient doesn't pay for the size of the scar. Patient pays or comes for the outcomes. It is the judgment call of the treating surgeon and team to decide how will he go home sooner the better. Not how will you go with a smaller and longer scar and longer hospital stay. No. So that discretion is what the team should have.
So one question which comes in my mind, because at the age of 92, my father had a compression fracture. Do we get this kind of falls and common compression fractures comes in good?
Very much, very much, very much, because that's one aspect of spine surgery or spine practice, which was earlier a silent killer, the so-called osteoporotic fracture.
Correct.
Osteoporosis was not considered as a disease as such till early 90s, or when better diagnostics let us understand them earlier, and better medications came in to treat it effectively. Now, I will say the most important treatment of osteoporosis is prevention. Most of the time, as an orthopedic surgeon, as a spine surgeon, what I see is a sequelae of an untreated osteoporosis. I always tell patients the fracture is an event, it is not a disease. The disease is osteoporosis. I cannot or I should not expect to fix a fracture and heal the disease. I fix a fracture, I heal the fracture. I fix a fracture, but I don't treat the disease. So once it happens, I should understand that, or the team should understand that it's a failure of the bone health. And apart from treating your osteoporosis, you have to treat your, apart from fracture, you also treat the osteoporosis. Now, then the question, doctor, I'm taking calcium for years together. Is it not treatment? No. Calcium is not a treatment of osteoporosis, it is supplement. When you give a treatment, it has to be a reason. Like you have fever, you go to a doctor, you're given paracetamol. Is it treatment? No. It is symptomatic relief. You're given an antibiotic for an infection. That is the treatment.
It's a very important point you're covering, sir, because there is a notion amongst patients that, if you have an osteoporosis or you have some bone deficiency, you take a lot of calcium pills and then it'll...
On the contrary, the other side, that if you take calcium, you'll get renal stones, which also is not valid. There are some sort of patients who have I have patients whom I advise calcium who take it for a while and stop it because XYZ told her or him that if you take calcium, you get renal stones, and he stops it. So then the benefit of the therapy doesn't happen, right? So you have to know when to take what. And calcium, even though a supplement, it is just like it is to be taken under medical supervision by advice, not randomly. Another question is asked, doctor, I take Horlicks, women's Horlicks since last 10 years. Will I get osteoporosis? I'll say women's Horlicks is not supposed to treat osteoporosis, right? You should have started preventing your osteoporosis at your 30 years of age. Now that raises a question, why? Because the most common cause of osteoporosis is postmenopausal osteoporosis, which is given in women. Now for a lady, to prevent osteoporosis, there are two important factors which peak at age 35. It is like you save money into your bank account. You save money into your bank account so that when you retire from active employment, you're able to withdraw it and sustain your life. Similarly, the peak bone mass in a female comes at 30 to 35 years of age. You should, at that point of time, having adequate calcium intake and weight-bearing exercises. Swimming is not a weight-bearing exercise. It's not good for the body. It causes osteoporosis. Whereas light gymming, running, etc. is good for the bones. So you should have started treating women's Horlicks not at 50 years of age and feel that you are protected. You should have adequate calcium exercise in your 35 years of age.
Plus vitamin D3, B12 also, some source of...
Yes. So vitamin D3 and B12 are part of the metabolic process in the calcium
absorption. Yeah.
So just taking vitamin D will not prevent osteoporosis. So that is when you have to have started preventing your osteoporosis. And next is, once you are in a high risk category. Now what is a high risk category? You are post-menopausal female after 60s, or your family history of fragility fractures, you have history of taking steroids for any diseases, you have history of taking anti-cancer treatment, you're on any kind of long-term steroid therapy, you have to have an evaluation for osteoporosis. Because most of the time, this so-called glucocorticoid-induced osteoporosis or post-menopause can be prevented, or you can prevent a fracture by taking adequate medical management, which includes not just calcium, it also includes adequate weight-bearing exercises, lifestyle modification, and drug therapy. Today in drug therapy, there are a huge amount of drugs which are very effective and very safe, which can prevent osteoporotic fractures. Another point again I like to emphasize is that osteoporotic treatment does not happen overnight. It's again like a bank account. You have to keep on investing into it so that you don't have to have a fracture later, and which also needs adequate follow-up.
So, last 2, 3 questions. How much has the rehabilitation part of spine care changed for betterment?
So I will put it two ways: a paralytic disorder or a neurologic disorder versus a degenerative disorder. A paralytic disorder like a spinal cord injury or a fracture or a degenerative disorder, etc., needs a lot of rehabilitation because of the disease per se and the sequelae of disease per se, like muscle weakness, lack of locomotor coordination, etc., contractures, etc. With respect to degenerative disorders, the so-called earlier, since you're asking about rehab primarily, a majority of the degenerative disorders are prevented or treated with physical therapy and strengthening of the back muscles. That is the preventive as well as curative solution. When it comes to post-operative rehabilitation, due to the minimally invasive or endoscopic surgery, etc., the surgical damage or whatever morbidity because of surgery is very minimal today. So, a true per se long term rehab is not required. Again, a degenerative disorder is a cascade of disorder. You have a disc prolapse at one level, you do a treatment, the surgery, water for that level, does not mean that you cannot have another level disc prolapse.
Adjacent disc.
So your rehab starts first, surgery comes next. So this has to go together. So that is the role of rehabilitation. When it comes to paralytical disorders or neurologic disorders with deficits and weakness, yes, rehab is the most important thing apart from drug therapy or surgery, etc., wherein again the new strides in technology has gone a long way in aiding ambulation or regaining your prior state of mobility and agility because of the disease.
So, what I have understood from our short conversation is that there is a lot of advancement in the diagnostic segment, early diagnosis, like what you explain about scoliosis. In the treatment, also, there are a lot of advances which has revolutionized the treatment, the minimum stay, minimally invasive, and all that. Why do you think still patients are scared of coming to a spine surgeon or getting a spine surgery done?
It's a very good question, sir. I'll try to address it like this. Today, when you have a heart attack, you have a MI, you go to a hospital, you do a basic investigation, and you are found of a block. The percentage of people who don't hesitate to go for an intervention is getting minimal and minimal. Why? Because the indication and skill of doing an angioplasty is becoming maximal. The indication, nobody will open up the heart to remove a clot today, right? If it is amenable. If you had to go with an open surgery, which has got its own amount of morbidity, it has got its own amount of rehabilitation, naturally the time taken to heal is longer. Same thing is with respect to spine surgery. There was a scenario probably 5 or 4 decades ago wherein you have to open up to see what is inside. Today, if I have to go for a surgery, before I put my knife on the patient, because of the advances in imaging, I exactly know what is the problem, where I am going to. I don't have to open and search. I can pinpoint and pick. So that difference has led a lot to the decreased morbidity. But we always say you should not reinvent the wheel. History is there for us to understand and why, to prevent the same mistakes again. So this is available to the common public, and everybody has a sad story to say about a prior open intervention done 4 decades ago by not a specialized guy. I will not say not a specialist, not a specialized guy, not a focused person who did not have the kind of intent. Spine surgery requires a lot of intense training. To come to a particular level of expertise, because it is not just diagnostic. It has got to have an element of clinical evaluation skills, an element of experience in interpreting the images and interpreting with the patient and correlating and interpreting the surgical decisions and also interpreting the outcomes. So it's a long, the learning curve is quite steep
Quite steep.
and long. So the time you come to a level of expertise is probably a decade or more to come to some level of expertise. I would say after doing it. Naturally, in this path, somebody would have got a suboptimal outcome. When all these collective suboptimal outcomes come together, there is fear. There is fear, and fear leads to fear mongers, and that leads to negative publicity or negative optimism. To add to it, this is a question which I'm asked very frequently when I go to a medical CME and give a talk. Doctor, who should treat spine surgery? Should it be a orthopedic surgeon? Should it be a neurosurgeon? Or could it be a physical therapist? Could be anybody. So when I was young, I said I'm really young. So I used to be annoyed. I had spent decade training in spine surgery, and I've been asked this question. Eventually, I understood that it is a common thing to be asked.
Yeah.
So I always tell, sir, if you have a car in your home and you have a driver, you and your wife both drives, who will drive in the morning when your daughter goes to school? Sir, driver. At night you have a heart attack. Who will drive your car to take you to hospital? Sir, my wife. I am the driver. Your wife is an orthopedic surgeon or a neurosurgeon.
That's a very good way of explaining.
I am a professional driver. You expect me to make less accidents. Similarly, I am a trained spine surgeon. When I am there, I am responsible. But if I am not there, anybody can drive a car. It could be an orthopedic surgeon or a neurosurgeon. Definitely not somebody not other than this realm who will do spine surgery. Right? So that leads to better outcomes.
But sir, if you look at the last question, if you look at our academic front, the per spine doctor population for 1,000 people, you still feel a long way to go, both in terms of actual spine surgeons and the spine surgeon specialist, with the example you gave with a steep, who has undergone that steep curve. What do you think we should do to improve that? Because that will also make an impact.
Sir, if you're aware, you're very well traveled in the world, that time wait to see a spine specialist in North America or in NHS in UK, you have any guess as to how long it is, or even in Australia? You have any guess as to how much it is?
No.
It's like 5 months, 6 months, etc.
Uh-huh.
And how long it is somebody in India?
Few minutes, yeah.
Few minutes. You want to still say that there is no amount of enough doctors available? It is not truth. It is not truth. Other than having the so-called barrier of specialization and talking somebody, I would emphasize that training the available specialist appropriately is more important than increasing the numbers. It is not important to increase the numbers. You can see in India anybody in 6 minutes or 10 minutes or one day. You're not in NHS or anywhere, right? Because of our population and our training opportunities. Now we have the Association of Spine Surgeons of India Fellowship, we have the National Board Fellowships, so many accredited fellowships.
Avenues to
as well as
upgrade.
Non-accredited fellowships, inland and abroad. So, and today information is very easy available on the internet or on any of those digital formats, right? I always say that, you can look at a YouTube video and see a procedure. How do you do the procedure? You can video call your loved one and see how it is. Can you feel them? Same is with surgery, sir. You can see a video and know what it is. The feedback comes when you touch it.
Tactile feel.
That's right. So you have to have all that kind of thing. So that has to be enriched, because that leads to better outcomes. It's not just a number of specialists.
What would you like to give as a final message before we sign off in this podcast?
A vast amount of your regular back and neck pains can be avoided with proper posture, proper postural exercises, and adequate rest. You go to a shop and buy a shirt or pant to your fitting. You don't go to a shop and buy something which was available. You go to work, you sit in a chair and table which is available. You might be 6 foot tall or you may be 4 foot tall. 4 feet tall. You think both will fit you well? No.
No.
A vast majority of problems are because of this. If you can buy a shirt and pant for your fitting, why not get your seat and table to your fitting so that that contribution to your back pain is decreased?
Very powerful message. Yeah.
Get this. This is simple things to ensure that you will sit and stand and live longer pain free than seeing a doctor. When you have the red flags which I mentioned, please see an appropriate specialist and please get investigations done only when it is required, not when always recommended. Once you have a particular investigation, etc., please follow a specialist advice other than Google to confuse you. Remember, early diagnosis is early treatment, better outcomes, and safer surgeries when indicated.
And the last message I would add is that don't fear spine surgery. We have good number of surgeons like Dr. Ranjith Unnikrishnan across India who can give better outcomes because of the change of technology, change of approach. So it's you fearlessly people can go to the specialist and get their spine surgery done or spine treatment done. With this message, I thank Dr. Ranjit for sparing his valuable time and giving so much of knowledge about the spinal disorders. Thank you very much.